All right, it's about 5 minutes after, so I think that we will go ahead and get started, although some people are still joining. I mean, the attendance at this is just massive, and we're just so happy to have this offering, and we're so grateful for people's ability to be here today. I'm Kathleen Adelgaze, and I am one of the pre-hospital domain co-leads, along with Rachel Alter, who's also here today. And we are just thrilled to have our speakers talking on the issue of mental health challenges, behavioral mental health challenges, and emergencies for pre-hospital providers. And as we get started, I just wanted to just have a disclosure that the EIIC is funded by HRSA, but the contents of these presentations do not necessarily reflect HRSA, HHS, or the US government. None of the speakers today have any financially relevant disclosures, and we will proceed from there. Just some housekeeping for those of you who are here today. At the very end of the presentation, we will provide a link and a QR code for getting CE, which is, we're really grateful, is being provided for EMS professionals by Prodigy EMS, and they've been a really nice partner in helping us with this. So I wanted to just share with the group before we get started, this Wednesday of EMS week is EMSC Day. And what does that mean? What is EMSC, or EMS for Children? EMSC is a lot more than most people may know. And the various components of EMS for Children are kind of shown here. We have our state partnership programs, which many of you attendees are from. We have the Innovation and Improvement Center, which Rachel and I and many of the people who helped organize this webinar are presenting. EMS for Children is also PCARN, the Pediatric Emergency Care Applied Research Network. It is NEDARC, it funds NEDARC, which does all of those surveys, the pediatric readiness work, both for hospitals, and then the annual EMS survey. And then EMS for Children supports targeted issues grants, which we'll hear about today. And then finally, it has launched a program around EMS fellows and scholars. And what I'd like to just, point out is that we have a presentation from one of our EMSC fellows, Dr. Kenshata Watkins. We have presentation on targeted issues, materials that were generated from funding through EMS for Children. That we think will be very valuable and great resources for those attending and for your organizations that you come from. And we have cutting edge research that we're presenting today on the impact of how EMS can apply some best practices to behavioral health patients in the out of hospital environment. So we're just really proud of the work that EMS for Children does to support care and really to support our EMS professionals in the country to take good care of children. We have 3 presenters today. They're all going to do something a little different, and we're really excited about the work that they're going to present today. Nicolaus Glomb is an associate professor of pediatrics and also global health at the University of California, San Francisco. His clinical home is at Benioff Children's Hospital in Oakland, California, where he works as a pediatric emergency medicine physician. And he is also a scientific advisor and researcher within the PCARN EMS affiliate research network. And some of the work that they've been doing is what he's going to share with us today. Intern Kenshata Watkins is a 3rd-year fellow in pediatric emergency medicine, also at Benioff Children's Hospital. And he also is the EIIC fellow for the advocacy domain. And he has done a lot of work with our EMS for Children program to really support EDI work and efforts. And then also, along with Dr. Glomb, has been doing some research into best practices for children in the out of hospital environment with mental health emergencies. And finally, we have Mary Fallat joining us today. Dr. Fallat is the chief of pediatric surgery and she's also an endowed professor of pediatric surgery at the University of Louisville. Her clinical home is at Norton Children's Hospital, but for those of you who may know, she's also the project director for Kentucky EMS for Children. And she has just really advanced work significantly in this country to help create some resources for EMS professionals in caring for children and also caring for themselves, as many of the encounters that they face are very challenging, especially pediatric encounters. So over the course of the presentation, we'll monitor the clock closely, because we want to be able to give time for questions, and there may be time depending on each section's each presenter's time about their ability to take questions immediately after, or we may hold questions at the end. Also, please monitor your chat, because over the course of the presentation, Rachel Alter will be putting certain resources and links into the chat that you can then use and download. And all of these resources will also be available on the EIIC website. They're available today, or they'll be available shortly. So without further ado, I'll turn it over, I'll go over the objectives today. So we have a couple key things that we're going to cover here today. With regards to the pre-hospital behavioral health and emergency management, we're going to review the current state of pediatric behavioral health emergency care, and hopefully learners will be able to understand the safety outcomes of pediatric behavioral health emergencies that are managed with an EMS-specific driven diversion protocol. Our goal is that learners also understand the impact of first impressions during mental health encounters, and then learn about future steps to improve pediatric behavioral health emergency care. And then with regards to resources for the EMS professional directly, we're going to cover ways to, quote, cope as this compassionate options for pediatric EMS at the scene of a child's death, and specifically understand the challenges faced by EMS professionals when encountering an out-of-hospital arrest or death, give you resources to increase your confidence in providing compassionate death notification for families, comprehend the parental grief response, and then recognize and mitigate secondary trauma in the EMS professional. So now, without further ado, I will turn it over to Dr. Glomb, who's going to talk to us about the safety of pre-hospital medical clearance for pediatric behavioral health emergencies. Thank you, Dr. Glomb, for being here today.
Great, thank you very much. And thank you all. Good morning and good afternoon from the Bay Area. It's such an honor to be invited to speak today, recognizing EMS for Children program and EMS week. So welcome everybody. Yes, I'll be talking about the project that we recently conducted here in the Bay Area, the safety of pre-hospital medical clearance for pediatric behavioral health emergencies. Next slide. I would like to thank our research team, Drs. Tarek Trivedi, Jacqueline Grupp-Phelan, David Schreiger, and Carl Spohr. Really phenomenal team that I've been able to work with and continue to work with on other projects. So thank you to all of them for their help. Next slide. We went over the objectives just a minute ago, but briefly, we'll be doing an overview of pediatric behavioral health emergency care, describe some of the demographic characteristics in EMS usage in Alameda County, California, and then examine the safety of outcomes of pediatric patients directly transported to pediatric psychiatric emergency services using an EMS pediatric behavioral health protocol. And then we'll discuss future steps to improve pediatric behavioral health emergency care. Next slide. So for background for this study, 30% of all pediatric behavioral health emergency department visits in the United States arrive by EMS. And 15% of EMS transport in the United States are mental health related. We all know right now, especially with the COVID pandemic, that the United States has experienced an increase in pediatric behavioral health emergencies, and it's actually outpacing the rate of growth of adult visits for behavioral health emergencies by 30%. And a majority of emergency department visits for behavioral health emergency are unnecessary, since most patients do not receive any medical or psychiatric treatment in the emergency department. On top of this, we know that Children with behavioral health emergencies are spending days, sometimes weeks in the emergency department, not getting the care that they need. Behavioral health emergency patients are sent to the emergency department, often resulting in significant utilization of resources in the emergency department and use of valuable clinical space. So what our team did is really set out to study the safety of a pediatric behavioral health emergency protocol developed to basically medically clear behavioral health emergency patients in the field and transport them directly to an emergency psychiatric care facility. Next slide. So our study, we actually conducted a study in Alameda County, which is on the East Bay. Alameda County has a population of 1.6 million. Alameda County EMS responds to approximately 125,000 calls and transports approximately 90,000 patients each year. They maintain a database, ESO Solutions, of all EMS encounters. And Benioff Children's Hospital, Oakland, formerly Children's Hospital, Oakland, is a designated level 1 trauma center for Alameda County. Next slide, please. In Alameda County, California, patients that are found to be a danger to themselves or to others are placed on an involuntary hold, or IVH. Alameda County has the highest rate of involuntary hold detentions in all of California. Alameda EMS uses a field screening protocol empowering pre-hospital providers to identify low-risk children with behavioral health emergencies who can be medically cleared in the field and transported directly to a regional psychiatric emergency service center, therefore bypassing the emergency department. Next slide. So this is a summary of the Alameda EMS protocol. So all patients, all behavioral health emergency patients are required to be transported to an emergency department, therefore would not be allowed to be sent to the psychiatric emergency department if they're less than 12 years old. Any patient with any medical complaint, and that includes ingestions, vomiting, a report of no food or fluid intake for more than 16 hours, any kids with known chronic medical conditions, if they have depressed level of consciousness, if their heart rate is greater than 120 or blood pressure greater than 190 over 110, or if the child has been outside of adult supervision for more than 24 hours. And all behavioral health patients, all other behavioral health patients can potentially be transported directly to a psychiatric emergency service. And this protocol is going to be in the slide deck at the end of the presentation for more information. And we can also provide the link in the chat. Next slide. For our study objectives, we look to examine the safety outcomes of pre-hospital medical clearance of pediatric behavioral health patients and directly transporting to pediatric psychiatric emergency services using this EMS behavioral health emergency field screening protocol. And then we described the mortality of patients being transported directly to the psychiatric emergency services. Next slide. So how did we do this? We did a retrospective review for all pediatric patients less than 18 years old. And looked at all EMS encounters between 2011 and 2016 using Alameda County's data set. Alameda County's EMS data set, like many EMS data sets, is encounter-based and does not include a variable to uniquely identify patients. Therefore, we developed a probabilistic-based matching strategy to identify unique patients in this large data set. We then linked the Alameda EMS data set to mortality data from the Alameda County Vital Statistics, and we identified the proportion of patients who were found to have a medical issue requiring retransport to emergency department after arriving at the psychiatric emergency services. Next slide. So for our results, I want you to focus on the highlighted left side of this graph. In summary, out of 38,241 total pediatric EMS encounters during the study period, approximately 25% were for behavioral health emergencies. making it the second most common transport behind trauma. Next slide, please. Next slide, please. All right, and the bars to the far right demonstrate the significant number of pediatric behavioral health patients that utilize the EMS system at more than one point in time. So during the study period, there were 208 children who had 5 or more involuntary holds placed by EMS, accounting for almost 21% of all of the involuntary hold encounters. Next slide, please. So of the 7,670 pediatric patients placed on involuntary hold and encountered by EMS, 41% of them met the EMS protocol criteria for behavioral health emergency and were medically cleared in the field and transported directly to the local psychiatric emergency service center. A total of 15 patients, or 0.5%, ended up requiring a retransport back to the emergency department within 24 hours of arrival to the psychiatric emergency service. And the reason for these transports are listed in the chart at the lower part of this slide. When linking the data to Alameda County Vital Statistics dataset, we found that there were 17 involuntary hold patients that died during the study period, and only 1 involuntary hold patient died within 90 days of an EMS involuntary hold encounter. And that patient was greater than 70 days from the encounter. Next slide, please. So the limitations of this project is that, we suspect that there are definitely some regional differences in the severity and the types of pediatric behavioral health emergencies, which could influence the safety of a field medical clearance protocol like the one in Alameda County. There is a possibility of possibly underreporting in the identification of retransports, which would prove to be failures in field medical clearance. And the protocol really only allowed for diversion for children greater than or equal to 12 years of age, leaving almost 11% of all pediatric patients that were placed on an involuntary hold during the study period ineligible for transport to the pediatric psychiatric emergency services. And unfortunately, there was no data on other outcomes after admission or discharge from the psychiatric emergency services. And we encountered limitations, unfortunately, in understanding the cause of death for the 17 pediatric behavioral health patients who died during the study period. And unfortunately, this was due just to the inability to obtain the cause of death from the Alameda County vital statistics. Next slide. So in conclusion, this EMS behavioral health protocol was safe as measured by the low rates of retransport and death during the study period. Patients who had at least 1 involuntary hold really disproportionately used the EMS system. And then utilizing the protocols established by Alameda County EMS, we know that 41% of pediatric patients with behavioral health emergencies were directly transported to the regional pediatric psychiatric emergency services, therefore bypassing medical clearance in the emergency department. And then failed diversion as measured by EMS retransport to the emergency department within 24 hours was extremely rare, occurring in only 0.5% of encounters taken directly to the pediatric emergency service. So as far as, next slide. As far as next steps, this and similar protocols can significantly decrease the burden on local emergency departments, and most importantly, can allow for a more timely mental health evaluation for these pediatric patients. We will certainly need to identify counties in the United States that have an existing pediatric emergency services, knowing that not every county has this available. And then the plan would be to develop further studies to prospectively study this or similar EMS behavioral health field screening protocols. Some agencies certainly may have limitations in their ability to transport directly to a pediatric emergency service. And this might be either because of reimbursement issues or requirements of having an ALS provider available at the receiving facility. So we need to be creative and innovative in our approach. And there are possibly utilizing, there are many EMS organizations that are coming up with community assessment and transport teams. Alameda County is one of those that has recently developed such program. And these consist of a behavioral health provider and a paramedic responding to behavioral health emergencies. So it is certainly possible that with these teams now responding to behavioral health emergencies in the field, this may improve the rate of transport to psychiatric emergency services. And knowing that every county in the United States does not have a pediatric or psychiatric emergency services or sufficient bed availability for psychiatric emergency services, the goal of this project really is to drive policy and legislature to increase funding for psychiatric emergency services for children. Next slide, please. So thank you very much for providing me this opportunity to speak with you about this project, and would love to know of any questions or comments. I'm also available via email listed on the bottom of the slide. I think we will probably move on to the next presentation and can address questions towards the end. And next we have Dr. Kenshata Watkins, who's gonna share a tool he has developed for how EMS providers can help to improve the care of children with behavioral health emergencies. Thank you.
Thank you so much, Dr. Glomb. There are 3 questions in the Q&A area, and I don't know if those are questions that you want to answer through the Q&A, or we can address at the end of the presentation. Dr. Kenshata Watkins joins us today also from Benioff Children's Hospital, and he is going to speak about the ABCs of equity, diversity, and inclusion and how it impacts behavioral pediatric mental health emergencies. Thank you so much for joining us today, Dr. Watkins. Take it away.
Hi, everybody. Thank you all for taking time out of your busy schedules to be a part of this today. I'm excited to be here. And so today I'd like to talk to you about the ABCs of equity, diversity, and inclusion, and focus on the pre-hospital context, particularly as it relates to pediatric behavioral health management. Next slide, please. So the pediatric mental health crisis was outlined in great detail in the Surgeon General's report, as well as with the AAP in 2021. In 2020, mental health visits to the ED increased by 24 and 31% for groups age 5 to 11 and 12 to 17 during March to October of 2020. Additionally, suicide attempts increased 51% for adolescent girls and 4% for adolescent boys during the early part of 2021 when it was compared to the early part of 2019. But I know that some of you already know this and knew it before the statistics came out, because you are literally seeing this before anyone else. However, it's still jaw-dropping to see those numbers and cause for alarm. Next slide, please. Because EMS personnel is the first point of contact for some kids experiencing a mental health crisis, any interactions you have impact subsequent interactions in the emergency department, the inpatient side, et cetera. I mean, you have the very difficult job of gaining a kid's trust in very little time, but you also have a very powerful point of view that none of us in the hospital have. You see the child in their true context. You may meet family members that we may never meet, or friends. You see the physical settings that they spend most of their time in their homes, as well as the communities they live in. And we know that all those factors really play a role in a kid's mental health. So you are allowed in, and you see the holistic picture. And those of us on the inpatient side, we really rely on your perspective. And finally, you are the bridge between other providers, both health and non-health. And you can be positioned to be an advocate, which I'm sure you do already, for kids in their most vulnerable states. Next slide, please. So these are the high-risk groups among kids experiencing mental health emergencies. They're youth with intellectual and developmental disabilities, those who identify as LGBTQ, gender nonconforming, racial and ethnic minorities, kids in rural areas, low income, and kids involved in the juvenile justice system, as well as the child welfare system, and those who reside in immigrant households. So your interactions with these high-risk groups are at even higher stakes because of the pre-existing vulnerabilities, and it may be more likely to have, the kid may have had more negative experiences in the past with health professionals. So, for example, Black youth suicide rates have doubled over the last 6 years, and kids who identify as transgender attempt suicide at a rate 6 times that of cisgender youth. And so youth who live in rural areas also experience this increased weight of suicide, and their rates are double that of those who live in the cities. And on the right here, you'll see an infographic highlighting the factors that actually influence pediatric mental health, some of which I spoke about. Next slide, please. So first, I wanted to take a moment to review EMSC's EDI strategic plan because I think it offers the definition of equity, diversity, and inclusion through a statement of goals. So goal 1 really speaks to everyone as being part of a vast community that not only respects diversity, but understands that it's vital to achieving equitable care. It references stakeholders and also partners. Stakeholders are people who have influence or sway in an institutional organization and may not be involved in the day-to-day activities of the organization, but help lay out the strategic things like the strategic plan for the organization. While partners for an institution are the folks who carry out the day-to-day task of the organizations and the day-to-day goal and on the ground really make those goals come to life. So goal 2 is it references EMSC's goal of improving by being flexible and exhibiting bidirectionality and a willingness to listen to the diverse groups of patients and their families. And then finally, goal 3, it reinforces the overall goal of achieving equity across the many different regions and looking at outcomes to ensure this equity is actually occurring. And so I use these goals to create the ABCs of EDI. Next slide, please. So we've gotten a glimpse into the pediatric mental health crisis and EDI, and now we can discuss further why it's so important in the pre-hospital context. I mentioned a number of high-risk groups earlier, and these are the same groups more likely to use EMS for mental health encounters. And EMS's role is very critical for the reasons I listed previously, but also because the EMS community's de-escalation training could be critical here, especially given the fact that people are 16 times more likely to be killed by law enforcement during a psychiatric-related call. Given that vulnerable pediatric populations are more likely to use EMS for mental health complaints, it's important to be aware of pre-existing disparities, particularly when it comes to interventions like restraint use. Recent data reports that Black and Hispanic adults are more likely to be restrained compared to their white counterparts, when other factors like history of mental illness, history of violent behavior are all controlled for. A group I'm working with has also found that not only are Black children more likely to be restrained with handcuffs, but also a child has a higher risk of being restrained when restrained as handcuffed as the percentage of Black residents in a neighborhood increases. And children are particularly vulnerable when it comes to restraints, and are more likely to be injured when restraints are applied. And in fact, the first guidelines regarding restraints came on the heels of a child dying during restraint use. Next slide, please. So how do we integrate EDI into our pre-hospital settings? Well, we're all aware of the ABCs we use to guide our clinical care in acute situations. They allow us to evaluate and treat, administer timely life-saving interventions, and then transform complexity of the different clinical scenarios into bite-sized parts. And it also creates a common language among providers. Next slide, please. So I thought this would be a really great way to be able to place equity, diversity, and inclusion within the same framework, because arguably addressing EDI can mean life or death for some. I realize that we're often in settings where brevity and acuity rule our days, and so these guidelines may seem a bit difficult to apply. And obviously there are situations where you can't ask your patient how they identify, but for the most part, these reminders are applicable. There are 5 in total, and I'm sure probably more, but I aim to capture some of the most important tenets of equity, diversity, and inclusion toward which EMSC is striving. All right, and next slide, please. So we'll start with A. A is for ask. So ask your patient how to identify. It's about resisting the urge to assume. And I've gotten the feedback that there's some hesitancy around asking this for fear of offending others. And really there's no guarantee that you won't offend some. But this could be a very important avenue of trust building between provider and patient. It can be as simple as asking, what words would you use to describe your gender or race, ethnicity? And when I've asked, I get the occasional, odd look from a teenager or adolescent, but most have not seemed bothered by it. And you may be the first adult who's given them the space to answer this question, and it could go a long way with a pediatric patient. Next slide, please. B is for be an ally. An ally uses their privilege and or social standing to advocate for others who may not have the same access or privilege. Allyship can come in many different forms, but it takes the courage and willingness to be uncomfortable and push past that discomfort. I really like the saying that allyship is not a noun, but it requires us to act. How many of us have heard a coworker make a joke or comment that made us uncomfortable? Allyship can come in many different forms, but it's really about standing up for not only what you believe in, but what is best for your patient. And being an ally can also mean educating yourself about disparities and vulnerable populations. Next slide, please. C is for check our biases. We've heard a lot about biases over the past few years because they matter in terms of how we engage with our patients and their therapies and workups and outcomes. Biases are defined as a set of beliefs or ideas that influence your relationship to another person, and it's usually spoken about in a negative manner. They can be implicit or unconscious, unconscious in origin or explicit, and we all have them. I listed a few examples on the slide. There's race and ethnicity, sexual orientation, gender, weight, age, socioeconomic status, disability status. Research shows that bias impacts our decisions as clinicians, and this harms our patients. For example, in the elderly population, elderly are less likely to be treated for suicide ideation, despite having the second highest rate of suicide of any group. And so age bias plays a role here. So by checking in with ourselves and colleagues, by simply asking, what else could be influencing how I'm viewing this person's pain or their history? It requires being honest with oneself and accountability so that we can break the cycles of prejudice. And since everyone has them, really it's less about blame, but more just really about embracing accountability. And so this is really hard work, and a lot of difficult feelings and things like that come up, but it's necessary if we're to achieve our goal of reducing health disparities. Next slide, please. D is for documentation. So now I know you're thinking, what does equity and disparities have to do with documentation? So documentation is huge and requires a reframing of sorts, because it can be seen as a way to see what we're doing wrong, but really it's about finding out what we're doing right and being able to reinforce those patterns of what we're doing right. So one way of doing this is by committing to using person-first language, which I'm sure you may have heard of before. It asks us to acknowledge our patient's humanity by not referring to the person as a disease, because we miss the entire person when we do this. And so instead, for example, instead of referring to a patient as perhaps a sickler, you can say or document that this is a person with sickle cell. And by simply allowing patients by simply interacting with patients in this way, this allows the patient to definitely feel seen as a whole person and not their disease. Next slide, please. E builds upon A through D. And so the evidence is clear that there are differences in the type of care we deliver to different groups of people, whether it's resuscitating and making the decision to use restraints or addressing pain. So E asks us to reflect upon these disparities and wade through the noise of our biases. This process is not about finger pointing or blame, but again, about accountability. And just like we work to perfect our intubation skills or our line placements, we may have to unlearn beliefs or ways of interacting, but it's all in the service of equity. And next slide, please. So remember your ABCs of EDI and support each other as we strive to be better providers and ultimately better humans. Last slide, please. Thank you all for your attention. And if you have any questions, please feel free to reach out to me at kenshata.watkins@ucsf.edu. Thank you.
That was fabulous. Thank you so much, Dr. Watkins. I really appreciate your time and also introducing the group to the work that EMS for Children is doing in this area. And for our last presenter, I'd like to introduce Dr. Mary Fallat. As mentioned before, she is with Kentucky EMS for Children, and some work that she has done has been to develop some resources for the EMS professionals. So at this time, we will turn our attention from how EMS professionals can care best for children to how they can care for themselves and the families when there's a really horrible event. So Mary, please take it away.
Thank you, everybody. This is titled Ways to Cope at the Scene of a Child's Death. Next slide. And the goal is to cover some of the issues regarding how you can give the worst news that you can possibly give someone at the scene. Understanding that EMS encounters this probably somewhat infrequently, but certainly it happens, and it's something that's terrible both for the family and for them. Next slide. It will come as no surprise to most of you that EMS is undervalued and overworked. One of the reasons is that EMS originated as a transportation system after the EMS Development Act of 1973. This means that federal healthcare policy traditionally reimburses ambulance services as a transportation benefit and not a patient care service. There is an essential curriculum, but not an advanced degree. And interestingly, it is often not defined as an essential service, despite the fact that we just went through a terrible pandemic, and obviously EMS was very important to the survival of many patients. The professional role is threaded with hazards and a risk of occupational injuries, and many volunteer services and per diem jobs still exist that don't qualify for health benefits. Next slide. The salary has also been kept almost purposefully low because of the previously mentioned reasons. In fact, the national average annual wage of paramedics is about $40,000, according to the Bureau of Labor Statistics, which is far less than the annual average salary for all occupations. When I looked yesterday, Hawaii was the state that paid the highest wage for EMS. Next slide. So consequently, and partly because of the reasons that I've mentioned, the suicide rate of EMS personnel is 5 times greater than the general population, according to research from Eastern Kentucky University. Next slide. This was a survey done in 2015. In the survey, suicide contemplation was defined as the stress a provider undergoes either as a result of a single critical incident that had a significant impact or the accumulation of stress over time. This stress has a strong emotional impact on providers, regardless of their years of service. Questions also included if they had ever contemplated suicide or attempted suicide. The orange bars represent the CDC national average, and the blue bars, the EMS provider survey respondents, which you can see were quite high with respect to both those who had contemplated suicide and those who had committed suicide or tried to commit suicide. Next slide. This was a paper published in 2019 that represented vital statistics information from 2009 through 2015. Of the deaths in that state during this time, almost 8,000 were categorized as suicide. The proportion of deaths attributed to suicide among EMTs was 5.2%, which was twice as high as non-EMTs in that state. Next slide. Code Green is a first responder website that is oriented towards mental health advocacy and education. It is devoted to telling the stories of people who either knew someone who committed suicide or someone who tried to commit suicide. Unfortunately, the site is having some technical difficulties right now, but it is a great resource for EMS providers who are feeling blue and need some resources. Next slide. So the rest of this talk is about the delivery of the worst news. Customarily, this is delegated to a physician in an emergency department, but again, we know that some individuals, including children, are dead at the scene. And none of us receive very much education about compassionate care and the delivery of bad news. I always remind people that regardless of how you feel about it, they will remember what you said and how you delivered this message. And if you deliver it compassionately, they will remember it in a kind way, but they will remember it first thing in the morning and last thing at night for months, because this is something that was tragic to them. Next slide. So in 2013, HRSA funded a project for colleagues and myself to develop resources for EMS providers who were exposed to death in the field. This is a targeted issues grant, and whether it was due to death or termination of resuscitation for perceived fatal injuries, this is devoted to trying to not only help the provider with next steps, which isn't something that is traditionally taught, but also guiding them to helping themselves. Next slide. So the project, since its completion, has been housed on the Kentucky Board of EMS website under the Kentucky EMSC banner. You can see where it's highlighted here. I'm pleased to say that due to Dr. Kate Remick's help, it is migrating to the EIIC website, and there are a number of people who are involved in this project, and I'm very grateful that they have not only recognized its importance, but helped us to modify and make it stronger. Next slide. So you can actually go to the EIIC and find some of the resources that are in the Kentucky website right now. And at some point, when we complete the transition, we will likely take it off the Kentucky website, but it will look like this. Next slide. And there are several drop downs that are already there. Each of these resources opens up into a pull down. Next slide. So for example, the first one is what you can do now, and you can see that it will open up to immediately notify the family of your plan, be clear, even if it's uncomfortable, silence is still golden. So each one of these has specific resources. Next slide. There are also a series of videos that are there that were produced by our simulation team at the University of Louisville. So these have already migrated and are there for you and are on both sites. Next slide. What is not there yet, at least not that I could find, are that there were several publications that were directly related to the project and led to the project or were a result of the project. And if you go to the Kentucky website and you see where the PDF is highlighted, you can actually click that, and the publisher has given us permission for you to get a downloadable copy of the entire manuscript. Next slide. There are also a number of other resources on the Kentucky website, including a first responder resource list, several suggested books, resources for families, and a reference list. These are not full PDFs because we could not get permission for most of those, but it's a reference list for educators, EMS providers, medical directors that is a full, I think there's 300 references for content for this project. Next slide. So in the chat, you will see a link that will lead you to the draft of this card, which is based off of our project. We're anxious for your feedback before we finalize it, and I'll just review what we have in draft. If you care to comment, we'd like to hear from you by close of business on Monday. And the 3 individuals, Ben Lang, who's a pediatric emergency medicine fellow in Austin, Rick Forrest, who's our chaplain at Norton Healthcare, who helped me with the COPE project and has been willing to continue to offer assistance. And then myself are working on finalizing this. So we'd love to hear from you if you have comments. And so on the right, you see the content from the card. It has our logo and then sets the stage for what it will be about. We anticipate this might be a back and front laminated card that you could put in your pocket. To set the scene, you should introduce yourself, find out the names of the family members that are there and also the child's name so that you can be personal about the messaging. Speak softly and slowly so that the individual can understand what you're saying and it can sink in. And it's good to establish what they already know with a simple question like, what happened here? Or what do you think happened here? And just see what they say in terms of the history. Next slide. To guide the family, you should be honest, avoid jargon, use a D words. You have to tell them that their child has died or is dead in a compassionate way. Express sympathy. Sympathy does mean that you feel sorry for them. I'm sure that there's no one who would disagree about that sentiment at this point. Empathy means that you're trying to actually imagine what it would be like to be them. And I think that takes a little while longer. You need to get to know the family member a little bit. Leave room for questions, offer to make calls if they need to call a relative, a pastor. Listen and respect what they say. And then there are several things to do or not to do to cope for yourself. These are much better elicited on the website, but you want to talk to your partner or debrief with other colleagues at the station. Be aware of what activities will help you personally to process. These are going to be different for individuals versus going out and binge eating or drinking alcohol or doing things that are not going to be of value to you. These things affect us, and I think ability to be self-aware that they will affect us and to understand how to make yourself move through the grief that you're feeling because of the family's grief is really important. Next slide. The most important communication from the parents' perspectives are the attitude of the informer, the clarity of the message, the privacy of the conversation, and the ability of the informer to accurately answer the parents' questions at the time. These come from a paper published with Marcia Levittown as the first author. It's quite old. It was published in 2008 in Pediatrics, and it's called Communicating with Children and Families from Everyday Interactions to Skill in Conveying Distressing Information. I certainly recommend it to anybody, especially anyone who's an educator. Next slide. There are some phrases on here that are good words that you can say. This currently says nurse acronym. I think it needs to say provider. But you can say things like, it looks to me like you're very sad. I understand that. Given what happened, I can't imagine how you feel. I can see how much you care or cared for your child. We will stay here with you until X comes, your family comes, the coroner comes. Tell me more about how you're feeling. Next slide. You can also ask about the child. You know, can you tell me a little bit about what Tommy was like? I think sometimes it helps people just to talk about their child. communicate at their level. If they're sitting, you should sit down. You should not stand up and look down at them. And if it's a coroner's case, which in some cases it might be, you may have some guidelines about whether or not the family can touch the patient or move the patient. But if they do allow the families to be with the patient, you can guide them in touching the patient and explaining what things are or what things were tried. You can offer water, tissues, etc. So I think the last slide is, yes, just to remind you of ways to contact us. The card is intentionally brief, so it will fit on a pocket card. We just want to make sure it's essential content, and it will also be downloadable, and we'll reference the website with a link and a QR code. So thank you for your attention today.
Sorry, I'll have to apologize for my crazy mouse. It was going all over the place, so I apologize for the slides advancing. But here is the QR code that I spoke about, and we have about 10 minutes. And so would love to see questions in the Q&A or in the chat. And just really fabulous presentations from all of you. Thank you guys so much. Dr. Fallat, I do want to note that Michael Pullen, I hope I'm saying your name correctly, Michael, is just saying thank you for recognizing the challenges that they're facing and wishing that his city and town administrations and the voters knew about that. A question from Christine Goff, I think maybe directed to Dr. Glomb, is about whether or not the psych facilities have a medical director on staff to medically clear the patients. Is that a resource that Alameda County is kind of relying on?
Correct, they do. They have a psychiatrist at the Pediatric Emergency Services Center that will assess the patient. And again, during the study period, that happened 15 times using the protocol. And most of the time, a majority of the time, it was either patients that tried to escape from PES, and per their protocol, they automatically retransport them back. The other reasons were patients that showed up and then initially didn't report ingestion in the field and then reported on arrival to PES. But yes, they do have medical clearance, further medical clearance and evaluation at the Psychiatric Emergency Service.
Wonderful. Michael Moody inquires or says that basically the information's been good. Samantha Hiller has a question about whether or not we can provide laminated cards. And I'm curious, Mary, if that is something that you have created for resources in your own state or best ways to possibly do that.
So the answer is no, not yet. This is all in evolution. This is the first rollout of the draft. So I think once we get feedback and understand the need and desire, then we would take next steps. I think, you know, laminators, we could make it downloadable and people could laminate them at home also.
Mm-hmm. And they're little, the information on the cards is a little big for like a badge card, but could be kind of converted into something a little smaller perhaps.
Right.
And Marianne Higbee asks about the psychiatric emergency department model and how many are there in your state and how much red tape is it to change the EMS protocols to reflect a PES as a destination?
Yeah, that's a great question. And that certainly is part of our next steps, is not only statewide, but across the country, how many counties actually have access to these psychiatric emergency services. And we know that not every county has access to this, but what we'd like to do is prospectively study this protocol in the counties that do have it. So it's going to be a little bit of a digging and surveying different counties throughout really throughout the country to try and figure out where this exists. As far as the red tape, the process, this protocol was developed by the Alameda County EMS Medical Director, Dr. Carl Spohr, and the Emergency Psychiatric Care Chief at the time. It required approval from medical directors from all of the 11 different county emergency departments throughout Alameda County. And so I was not a part of the development of this protocol. So the amount of red tape that they had to go through was, I can't speak to that. But I do know that it was a collaborative effort of all emergency departments and Psychiatric Emergency Center in Alameda County.
Yeah, that's it's a definitely regional situation for sure. And I think your point is, if this is working, then, advocating that other states and legislatures, work to make similar resources available. Michael asks in the Q&A about whether Alameda County allows chemical restraint. And he's thinking of some of the recent law changes for ketamine in Colorado.
Yeah, that's it's a great question. They do have a protocol for chemical restraint, and that's Versed for Alameda County. And there were other questions asking about, did you find that a number of these patients were restrained? And I responded to that question, but just a quick summary of that. We did notice, as we were going through the behavioral health emergency information, that a staggering number of these patients, surprisingly high number of these patients, were actually being restrained. So what's possibly unique with Alameda County is both police and EMS show up for every behavioral health emergency response call. And it is police that would end up handcuffing patients for various reasons. So this actually led us to do a deeper dive into this, and we actually conducted a completely separate study looking at disparities in restraint use in this population, which was led by Dr. Kenshata Watkins. Kenshata, you want to just provide a really brief summary of the findings?
Yeah, so I mentioned some of the findings in my presentation, but we found in a small subset that Black children are more likely, 2 times more likely to be handcuffed when presenting for an behavioral health emergency. And the handcuffs usually, as Nick stated, comes at the hands of law enforcement. And additionally, we found that kids are more likely to be handcuffed as their neighborhood context increases in terms of the percentage of Black residents. So those are 2 of the big findings. The ones that we didn't find this association with were chemical restraint use. So we did not find a relationship between chemical restraint use and the children that were experiencing behavioral health emergency.
Yeah, it's pretty impressive. The situations that we're still facing, and the mental health crisis is really exacerbating those inequities in care. So I think that it's just been fascinating. I will say in Colorado, sadly, we similarly have crisis stabilization units. We're working on alternate destination protocols. We don't, as Mary Fallat pointed out, that the challenge is that, as a transportation service, you only get reimbursed when you're transporting, and certain states only reimburse if you're transported to an emergency department. And so that really drives EMS towards hospitals and not towards perhaps better facilities to care for certain things. And the ET3 work out of CMS is working to kind of address some of that. But in Colorado, we started a whole series of crisis stabilization units, which I think have been a nice resource for the state. However, it was only after the Aurora Theater shooting that legislation was passed. And so you need, sadly, to prompt legislators to kind of act before sentinel events occur and stuff. So it's just been really interesting to hear all the great work that's happening across the country and in your communities. And we're so grateful for your time today. I think that is all we have, and see that people are dropping off the presentation at this point, but want to just thank everybody for their time and attention today. And again, please go to the Prodigy link there and get your CME, and we're really appreciative of your time.